And radiosurgery is frequently used, and there are still a variety of questions open. So what's the role of radiotherapy in different grades? What could be a future role of medical therapy? And is molecular profiling meaningful? So to answer all these questions, EANO did put together a task force already in 2016, and we published a EANO guideline for the diagnosis and treatment of meningiomas. And meanwhile, 2.5 years ago, this has been updated to a new guideline published in Neuro-oncology. And this is the team, and you might be aware that the number 2 in this team is a Greek person. He's on this board already, Pantelis Stavrinou. He will talk later, I think. And all the others are separated all over Europe according to the different specialities, neurosurgeons, neuropathologists, radiation oncologists, neurologists, and so on. What does a guideline committee do? So it checks all the literature, and the evidence is weighted, and depending on the weight of the evidence, recommendations are drawn. So evidence is classified into class 1, prospective randomized blinded trials, or even reviews of RCTs. Class 2 is prospective matched pair cohort studies. Class 3 is any other control trial. And the majority of the literature in meningiomas is, of course, class 4. About 80% of everything is class 4 only. And you can draw recommendations, level A, B, and C, as stated on this slide. And there are many so-called recommendations, which is only good practice points, which are based on class 4 evidence only. So what about therapy of meningioma WHO grade 1? So in general, you need individualization of therapeutic approaches. There is no one-size-fits-all for every situation. And if you have a meningioma and the patient is completely asymptomatic, you should observe. This is a class 3 evidence and the recommendation level C. If therapy is needed, surgery resection is still the therapy of first choice. And this is class 2 evidence that this is quite high in meningioma, and the recommendation level is B. And also the well-known Simpson classification is still valid. So the acronyms cross-total resection and subtotal, which is used in image-based clinical studies, is not the real good stuff. If you can do your surgical observation, you make a Simpson classification, this is a good practice point. And Simpson grade 1 resection, so complete resection with anything, should be intended. This is also class 2 class 2 evidence, recommendation level B. And if you have a look on preoperative embolization, it should be reserved for very rare specialized cases. There is not enough literature about this to have a stronger recommendation as just a good practice point. If you have a look on stereotactic radiosurgery, this can be an alternative to surgery in small tumors. We have class 3 evidence, and the factors are the condition of the patient. So an old patient in very poor condition could be a good candidate for stereotactic radiosurgery, and also the size and location of the tumors. Be very careful with the wish of the patient. A wish of the patient is okay, but a wish is not evidence. So your job as a doctor, as a neurosurgeon, or as a neuro-oncologist is to advise the patient properly and not just look at the wish of the patient. Stereotactic radiosurgery is also a good idea after incomplete resection, and the typical technique is 14 to 16 gray single fraction. Maybe you will have a talk about radiosurgery later in this session. Radiotherapy can be an option for very large, inoperable, or even recurrent tumors. And the techniques vary a lot. It can be intensity modulated radiotherapy, or even fractionated stereotactic radiotherapy, 50 to 60 gray altogether. And there still is no role of pharmacotherapy, meaning chemotherapy, in meningiomas grade 1. What about a tumor like this? If we have a look on this thing, there are a lot of ugly vessels here and here. The tumor goes down far to the skull base and through the skull base. If you have a risk assessment, so it's clear, if you have a tumor like this, you need to operate. But should you be radical in any situation? So if you compare surgical risk versus extent of resection. So one might think the relation could be linear, but it's not. It's exponential. You can do a lot of resection. You operate until you have 70 or 70% resection, and you have a very low surgical risk. If you go to 100%, you end up with a surgical risk in a large skull-base meningioma, maybe 30%, 50%, even more. There are cases like this. But if you agree with the patient to leave a small part in, maybe you do a 80% resection, you end up with a risk like here, maybe below 10%, and then it's doable. So it's also in the guidelines to do a combined approach, a hybrid thing with subtotal resection, low risk resection, plus radiosurgery or fractionated radiotherapy. So you combine the effect when you have a very, very low risk for both approaches. What about the grade 2 meningiomas? So also here surgery is therapy of first choice, class 3 evidence, recommendation level B. But radiotherapy is recommended after incomplete resection and in case of progression. But we do not know what is the role of radiotherapy after complete resection. So some centers do radiotherapy after complete resections, others do not. In our center, we are still, sometimes we do it. If the surgeon is quite sure there is nothing left, we observe. So the so-called ROAM study, which is also an EORTC study, it's still on the way. The randomization has been finalized. The patients are observed. And Michael Jenkinson is the head of the study. I think in end of 24 or 25, we expect the results. And there are some data that pharmacotherapy can be considered upon progression, but it's not clear which medication has to be used. In the grade 3, radical surgery is absolutely needed. And since radical surgery is really needed, you have to talk, or you should talk with the patient about accepting neurological deficits, because the alternative could be very short survival. And resection should be followed by radiotherapy, at least 54 gray. And it's a very disappointing thing that we still do not have really standardized pharmacotherapy. There are little data about pharmacotherapy, about different drugs. There is differing class 4 evidence for different drugs. We have a very well-designed EORTC trial with trabectedin from Matthias Preusser from Vienna, the EORTC 1320 trial, but it was negative. So the control group did even slightly better than the therapy group. So we cannot recommend anything for pharmacotherapy, even not in grade 3 meningiomas. What about the follow-up intervals? So there are no hard data, no strong recommendations about the follow-up intervals. The follow-up depends on the WHO grade, on the Simpson grade, the fact if some radiation has been done or not. Depends on size and location of the tumor, and also on the condition and the age of the patient. In general, the EANO task force recommends to do the first MRI in a suspected grade 1 meningioma after 3 to 6 months, and then annually. And if you ask me why do a first MRI after 3 months, so metastasis from cancer can look exactly like a meningioma in some cases. So if you have a young or even medium-aged woman, we always think on metastasis, do the first MRI early. And if you're sure it's not growing, you do the MRI yearly, annually. If you know it's a grade 1 meningioma, if you have resected, you also do annual MRI for a period of 5 years. And after that, you can switch to every 2 years. In elderly patients or in very ill patients, where in this patient, a very close follow-up wouldn't have any consequence, you can leave it. In the grade 2 meningiomas, we recommend MRI every 6 months, after 5 years annually. And in the grade 3 meningiomas, it depends on the growth dynamics of the tumors. Every 3 to 6 months, maybe even more often, more frequent. Some patients you have to follow up like a glioblastoma. So what's the focus for the next steps? Maybe you are interested in that. Is a molecular genetic analysis of meningioma disease important? Yes, of course it is. There are many groups working on development of targeted therapies, and many groups like our development of targeted imaging. And if you look at the expression profile of meningiomas, like ACT1 mutation, small mutation, NF2, and so on, and so on, and so on, look on the right side of the table. There are many potential drugs and drug classes which can interfere with these targets or biomarkers. And we are focused on the somatostatin receptor number 2. And we've established a receptor 2 specific PET imaging. And just for example, you have a post-operative control MRI of a left temporal meningioma. So the MRI looks absolutely clean. There is nothing left. And if you do a dotatate or a dotaToC PET with a radiotracer gallium, you see several spots close to the sinus, cavernous sinus, close to the petrous bone, or even lateral. There are still positive spots of the meningioma, which are not visible in the MRI. And if you have a grade 3 meningioma, which is already metastasizing all over the body, we can do a wonderful staging. You will find all the meningioma grade 3 spots in the brain and the skull, and also here in the lung. You also can use it for theranostics, which is a very modern word. You can combine the same thing for diagnostics and also therapy. You just need to exchange the the tracer. If you use gallium-68, it's a very soft thing, good enough for diagnostics. If you use 177 lutetium, it's a very hard radiotherapeutic. You can do therapy, you can kill the cells. And this is a scheme for peptide receptor radionuclide therapy, the PRRT. In the very beginning, you do a diagnostics. You look where are the focuses of the tumor, and then you do 3 cycles of the therapy. You do another diagnostic PET in the end, and hopefully you see there is nothing left. So this is one of the outlooks of advanced meningioma therapy. And the key recommendations right now are that observation should be the first option in asymptomatic meningiomas. Don't operate on anything you are seeing. Surgery is still the most important treatment in all grades. Radiosurgery, much more than fractionated radiotherapy, maybe complementary therapy, or even an alternative in certain cases, certain situations. Unfortunately, there is still poor evidence for pharmacotherapy. And I hope I have shown you that PET imaging is very, very valuable. And there are several targets for medical treatment of grade 2 and 3 meningiomas evolving. So molecular genetic profiling is absolutely necessary. And for this reason, please get tissue. Don't resect and throw the tissue away. Store it. Do your own research or keep the research of others. And if you find a new drug, it's very sensible to have tissue of your patient. You can, maybe years later, you can go back to this tissue. You can look, does he have some expression profile? And then this patient can have your drug. So thank you very much for your attention. I'm open for questions.
Thank you, Professor Goldbrunner. Very nice talk. We are happy to have you with us. And let's go to the audience for comments or questions. So if not,
Was quite clear.
sorry?
So obviously it was quite clear.
Yeah, yes, it was quite clear. Yes, yes. And with EANO guidelines, it's more clear than ever. So if somebody has
a question, President.
Yes.
Yes, I read that some stereotactic suggest for gamma knife in the small, no incidental meningioma. What is your opinion about this?
So if you have a small incidental meningiomas, the best thing is to do nothing.
Okay.
That's the recommendation. I know if a patient with a small meningiomas comes to a neurosurgical department, many young neurosurgeons like to resect it because it's fun. If it comes to a gamma knife or cyber knife department, people like to irradiate it because it's fun. Maybe there is also some money behind. But if the patient is not really threatened by this small meningiomas, the best thing is do nothing.
Mm-hmm.
Thank you. I agree with the professor, but because I read, this is the reason that I asked it. Thank you.
Thank you. I understand.
Yes, I think we have to change our strategy with this EANO guidelines for the best of the patient. So if